Started?
Yeah, I think so.
Excellent. Thank you everyone for joining us today. It's a pleasure for me to have Dr. Nero with me as we talk about improving cardiac health. For those of you that don't know me, I'm Jeff Scott. I'm the CEO of Section 810 Communications. We're a training and development company based in Greenwich, Connecticut. And while a lot of the work we do has to do with communication skills, leadership, team building, today's a little bit different as we focus more on health and wellness. I'm really fortunate to have Dr. Nero with me today. So Dr. Nero, thanks again for spending the time. I'm so glad that you're with me.
My pleasure. This is going to be fun.
It is going to be fun. I'll give a more formal introduction in just a moment, but some quick housekeeping items for the audience. You'll notice everybody is on mute and off camera. We do that just to avoid too much distraction, noise in the background. However, we want this to be an interactive, engaging conversation, really. You have that opportunity, as I mentioned a moment ago, to use the questions and chat area, and I'm looking to the side of my other monitor to see if there's questions coming in. Feel free to bring those up to us as we go through the presentation. We're going to focus on 6 primary areas of discussion as we go through the next 55 minutes or so. And with any of those or outside of that, feel free to bring those questions to us. You'll also be able to raise your hand. If you want to ask a question verbally, you can click on the hand icon and that'll raise a hand. I'll periodically look at that to see if anybody wants to be unmuted and ask a question verbally. Just to make sure that you can see Dr. Nero and me and you can hear us speaking clearly, would you all raise your hand? It's that hand icon. If I could get a look at those hands, I've been presenting for over 35 years, more than I'd like to admit sometimes, and I found there's nothing worse than doing a presentation when no one can hear you. So it's always nice if I know people can hear us. So I see the hands up. Excellent. Thank you so much for that. And it's great to see some familiar names on the list as well. So by way of formal introduction, Dr. Tom Nero is a clinical cardiologist, and he's the director of cardiovascular research at Cardiology Associates in Stamford, Connecticut. I'm really fortunate to have him as my personal cardiologist as well. He leads one of the largest private practice research groups in the Northeast, and their trials run the gamut, everything from treatment of obesity for primary prevention and advanced diagnostics to acute therapies for heart attack and strokes. And they're also active in interventional trials with aortic, mitral, and electrical disease. In addition to running a large practice, Dr. Nero is also very active working with a number of athletes and is himself a retired and reformed triathlete. I am still trying to understand, Dr. Nero, what it means to be a reformed triathlete. Maybe you can share about that when we get into the exercise portion.
Yeah, sure. But the real answer is my wife asked me to stop.
Okay, well that makes sense. See, that was a simple answer. Didn't even think about that one. So with that, thank you again. What did I miss? What else would you like to share with the audience as far as your background?
No, that's about it. I mean, I went into medicine a long time ago. I always essentially assumed I was going to become a doctor, and I went into medicine. And as I sort of continue to progress, there were always more questions that I had than could be answered by what I was doing. And that's how I ended up doing critical care cardiology, interventional cardiology, and how I ended up doing more research now, because I'm finding that as I get older and as my hair gets grayer, I'm getting more questions than I have answers. And one of the wonderful things about medicine is that the more that we know, the more that we realize we don't know, and that you have to really continue to ask questions, revisit the old questions, and go through and try to get new and better answers. And a lot of the stuff that we're going to talk about today, I may sort of lean back and say, 20 years ago we thought one thing, but now we think something else. And sometimes what we thought 20 years ago is correct. So it's been quite interesting. It's been a fun ride.
Awesome. And I'm looking forward to discussing some of that. One of the things I enjoy about having you be my doctor is I'm learning a lot, not just only because I'm not a cardiologist, but you're on the cutting edge of clinical research. And some of the things you've shared with me, Dr. Google, which is probably the worst doctor in the world, doesn't give me those answers. And so you've been really enlightening to me as we talked about that. And just a very quick background, the reason we're conducting this session today is I was both unfortunate and fortunate enough, believe it or not, to have a heart attack about 8 months ago. I say unfortunate because it was one of the most difficult experiences I ever went through, completely unexpected, woke up in the middle of the night with very unusual symptoms, to find out I had 70 and 90% blockage, was having a heart attack, had stents placed that closed a week later and that had to be redone. This journey over the past 8 months, the fortunate part is I've learned a lot and I've made some really drastic lifestyle changes, and it's improved my health dramatically with my cholesterol, my A1C, my sugar levels, my health, my weight. So many things have improved, and from that standpoint, it's been a really big blessing. And months ago, Dr. Nero, you and I talked about this, and I said, would you be willing? I had no idea at that point. You did your own podcasts and you really enjoy educating, but we talked about this because my goal in today's session is to help people avoid what I went through. Maybe learn some things and not be as stubborn I was with not listening to my doctors in the past and ignoring some of the risk factors. So with that, let's jump into the first topic I wanted to discuss, and that is symptoms and risk factors. So many people talk about hypertension, high blood pressure, cholesterol, diabetes, which were my nemesis, and obesity. Talk about that from your perspective a little bit. How much emphasis should we put on those risk factors, and what should people really be looking for?
Well, yeah, I think that there's a number of ways of answering it. I'm going to start off, and so I don't have to repeat this over and over again, that there's a number of ways of answering every question. But the most important things that we know about cardiovascular disease come out of these basic risk factors. And we've known these risk factors since the original Framingham study, which came out in 1948, where they looked at, I want to say it was about 5,000 people in Framingham, Massachusetts, that were mostly white, mostly men. And they said, okay, in this population, who ended up having a heart attack? And they went back and they found these main risk factors, like you said, smoking, hypertension, high cholesterol, diabetes, obesity. They added in things like sedentary lifestyles, abnormal, bad diets, and family history. And that's been the basis of how we've been looking at this for decades. It is still true. These things really are those risk factors. They really are important, and we will always look at them. And I think that that's an important piece just to start to as the background. I think there are going to be better ways of looking at heart disease and better ways of identifying risk than these, but these are cheap and easy. Everybody knows it, right? Most of the people who are listening know what their cholesterol is, know what their blood pressure is, and we can do a risk factor analysis. Now, one of the interesting things about risk factors is that it's a risk over a 10-year period of time of whether you're going to have a heart attack or not. It isn't telling you that you're going to. If you have a risk, if you're at 2% risk, there's still a 2% risk that you will have an event, regardless of these other things. So, yes, it is important, and yes, you should know this, and yes, if you are at higher risk, you should be being evaluated and be under somebody's care so that you can reverse these things as much as you can. But it doesn't mean that you're at zero risk. And we can go in a little bit about what other things we can look at that will identify people as being high risk.
That makes sense. And it's funny, when we talk about the risk factors, I knew that for years, I was type 2 diabetic. I had high cholesterol in the mid 200s range. Nothing seemed off the charts. My diabetes wasn't good. And we're going to talk about tests in a moment, but all the other tests I was taking showed that it seemed that I was good. But you had me do one cholesterol test, which is, I think, LP(a), as my primary care doctor called it. And you said that was, in your opinion, the smoking gun, and yet no one had ever tested me for that previously. So what about the different types of cholesterol that sometimes go undetected?
So when you're talking about cholesterol, it's not just cholesterol. So there's a cholesterol number that we all know. This is your total cholesterol, but that doesn't really tell the story. First thing you do is you go into LDL cholesterol and HDL cholesterol. And we always talk about the LDL cholesterol being the bad cholesterol. The higher your LDL is, clearly the higher your risk is. HDL cholesterol, unfortunately, is not a good indicator of health. We used to say that if you have high HDL cholesterol, you're protected. And now we know that that's no longer true. Low HDL cholesterol is a high risk factor, a significant risk factor. Very high HDL cholesterol is also a risk factor. So, I think that the total cholesterol number is very misleading and the ratio is misleading, and we sort of have to move away from that. In the LDL, there are different kinds of LDLs as well. And, there's a whole bunch of research that's going into the different kinds of LDLs, the different kinds of HDLs. But in general, a high LDL is just bad. And I say that anyone whose LDL is over 100 baseline, it's bad. And 130 is worse, 160 is worse, 190 is really bad for LDL. Beyond that, there's something called particle numbers and kinds of particles. I don't know whether everyone has to get that, but when I'm trying to find the granularity, I will often look at the kinds of LDLs and are they big and small and those kind of things. The one though that everybody should get once in their lifetime is the lipoprotein little a. Lipoprotein little a is a kind of LDL cholesterol that has a special protein on the outside of the cholesterol molecule. So if you think of this as all your cholesterol and that the outside is defining the LDL cholesterol, there's a special protein out there that increases the risk that you're going to have a plaque in your arteries. It increases the risk that you will have clots if that plaque ruptures. And it also increases the risk of inflammation. And I like to think of those as being sort of the three pillars of why unstable disease occurs. And this molecule hits all three of them. It increases the clotting, it increases the inflammation, it increases the plaque. So we think that in general, LP little a is about 6 times more atherogenic than LDL. And it amplifies the bad LDL cholesterol that you have. So in many patients who have events earlier in life, family histories, but really anybody, we should be looking at their LP little a's. And that's a very nice thing to sort of say, yeah, you're higher risk than we would think, even though you look perfectly normal, you got this thing. The problem with LP little a is that you can't treat it yet. We're involved in a couple of clinical trials for treatment of LP little a, and we will have the answer sometime in 2025, 2026, with a medication probably being available around 2027. But right now, if you have a high LP little a, what do? And the answer is that you're going to get your LDL cholesterol even lower than you would otherwise get it. And this is one of those key things that now physicians are starting to hear about. I was actually listening to a lecture recently, and they said only about 3% of patients in the country are getting this test, although everyone should probably have it once in a lifetime. And with that, if their LP little a is higher, and we can go into numbers, but if it's higher, then they should be on cholesterol medication, getting their cholesterols lower, be taking an aspirin every day, and if they already have coronary disease, maybe multiple blood thinners as well. So it's an important one that a lot of people haven't been talking about. We've known it for decades, truly, but now we have sort of a pathway of how we're going to treat it now, and then we have potentials of treating the LP little a itself in the future.
Yeah, that's an interesting one, because when you first told me about that, I said, is this caused by bad diet, lack of exercise? And you said no, and you can't fix it with better diet and more exercise. It's taking the other risk factors like the LDL. I mean, I'm so happy my LDL came down to 17. I've had other doctors say your total cholesterol is 65, not just the LDL. And yes, because of some of the meds you put me on and the diet and the exercise routine I'm in, but it's because that LP little a, it can't be affected other than by medication. So I think that's good advice. Everybody should get tested once in their lifetime. I think that makes a lot of sense.
Yeah, and if you have it, then your family should be taking it as well, because it's genetic. And there's clear GWAS studies that looked into the genetics of this and that it's inheritable. Although there is some wild type where it can just be in you and not be in other people. But if you have it, kids should be tested in order to see if they have it, because maybe that will help them to decrease the risks over their lifetimes. And a lot of what we talk about now is decreasing risk over lifetime, not just waiting until you're 55 or 60 to get treated. And in many ways, we missed some great opportunities here where we should have been treated much earlier.
Yeah, it's easy to think when you're younger, I don't have to worry about that. I'm young. Why do I have to think about that? I look back at my own life and think that for sure. That's a good segue into the next topic, which is some of the medical tests, the predictive tests that exist today, and some of those limitations. I knew I was high risk with diabetes and cholesterol. I've had stress tests, sonograms of my carotid artery. I've done the calcium heart tests, all those different things, and everything kept coming back saying, you're good, thumbs up. And yet they weren't really finding it. And specifically the calcium test that is supposed to be indicative if there's a problem, I know they told me in the Widowmaker that LED, it had a little bit, but it was really low, and yet that's where I had 90% and 70% blockage. What are we supposed to do with that?
So I'll plug my podcast for a second. So Patient Pulse is the podcast for patients, and Future Pulse Cardiology is the podcast for researchers and other cardiologists. And I recently did a podcast with the guy who helped develop coronary calcium scoring, a guy named Dr. Matt Budoff, who's at UCSD. He's brilliant guy. But he admits, and we all know, that there's limitations to every test. And the coronary calcium score is really super cool because it's cheap, it's easy, it doesn't put you a lot of risk, and it gives us a nice way of identifying people that are at higher risk than we would otherwise assume. But it can miss people who we think are at lower risk because it's showing calcium. Calcium isn't the problem. It's the plaque that's underneath the calcium. So the calcium goes there and sort of goes into where the plaque is. So the more calcium, the more plaque you have, the more calcium you have. But early on, you can have a lot of soft plaque and it won't be calcified. And those patients can be missed because they didn't have an opportunity to be calcified. So younger people, you won't see the calcium there yet. If you have a lot of soft plaque, you won't see the calcium there yet. So calcification isn't everything, but as a cheap and easy study, it's a really good study. So in patients who have high family risk and who have absolutely normal lipids, I will often just say, okay, get a calcium study and then we'll decide whether we go forward. Patients who are at high family risk and whose calcium studies come back normal, I'll then go forward for something called a CT angiogram. CT angiograms are like a supracoronary calcium score, where we look at the arteries itself, not just the calcium on the outside, but we look at the whole artery. We can see the plaque, we can see soft plaque, we can see hard plaque. And then if we see a lot of soft plaque, you're still at high risk for having cardiac events, and much higher than the calcium score is adding it. So very often I'll move forward to that. In Europe, they're moving forward to using that a lot more often. There's reasons why we don't use it quite as much in the United States. They're mostly historic. But I think that within the next 2 years, maybe 3 years, we're going to see that the majority of people are going to be doing this kind of study to look at their coronary arteries and to reevaluate their plaques. Here's one of the cool things, or interesting things. I'm not sure it's cool, it's actually interesting, is that stress tests do not show you this. Because if your artery is open and you have a lot of soft plaque, you're really high risk, there's a lot of plaque that could rupture, but it's open, your stress test is going to be normal. Because stress tests only show you when you have a narrowing there. And so it's only that part that you're going to identify, and that narrowing may not even be important to you. The soft plaque, though, is super important. And so, again, we may be moving away from stress testing for patients who are asymptomatic or talk about risk factors. We might use stress testing only for patients who are symptomatic, but probably we'll move over to CAT scans. And then there's yet another new thing that's coming down the line called fat attenuation index, which is looking at these plaques and looking to see whether there's inflammation in the plaque. And that hopefully will be available in the United States probably in the next year and a half. That's available in Europe right now, and they're trying to bring it over to the United States, and they're looking at funding and all that kind of stuff in order to do this. But it's super cool, super interesting stuff on looking at more of the morphology or the kind of plaque that's there and whether that plaque is going to have a problem in the future. And that's really what we need to find out, right? Is what your risk is now, what your risk is in the future, and are you at high risk and we are not seeing it? And could there be something that we could look to see that the risk is attenuated by our therapies? And just to give you an insight onto me, I have an LDL of 100. I do not have any other significant risks. Eat pretty well, I think, mostly vegetables and fruits and whole grains and whatever. And yet I had some inflammation in that artery. No plaque, but I had inflammation there. And based on that, I started myself on a statin with a goal of getting my LDLs really, really low.
Okay.
And I do think that that's going to end up being an important piece as we go forward.
So do you think it's advisable for the audience, those that have a cardiologist, to speak to their doctor, or those that don't, to speak to their primary care and say, hey, what about these other tests? Should I be tested for Lp(a), or should I have this other type of calcium test?
Yeah, I think that everyone should get an Lp(a). Once in a lifetime, just get it. It's one test. And it may not be easy for your primary care doctor to understand that test, but if it's elevated, then that's a good reason to be referred to a cardiologist. They can then talk to you about the risks and benefits and what we do beyond that. As far as the coronary calcium score and CT angiograms, I leave that up to an assessment of their underlying risk and trying to understand, are you at higher risk than what we think? And I'll often use those tests to determine whether or not I'm going to be more aggressive with statins or less aggressive with statins. Statins are the main treatment that we're going to give right now. In the future, there's going to be other options beyond statins. We actually have 4 different treatments for cholesterol right now, but there's going to be even more things coming down in the future about treating inflammation, treating different types of plaques, treating different types of lipids. So we're going to be much more nuanced in the future, and hopefully that diagnostic testing will allow us to determine which way we're going to go with our therapies.
Okay, very good. I see some questions coming in. Please keep the questions coming. Let's tackle the third topic, and then we'll come into some of those questions in just a moment. But the third thing we wanted to talk about, and you mentioned diet, and I know that you've been very encouraging of me to get more into a vegetable-based diet. And that's one of the things that we talked about early on. But when we look at that trifecta, diet, exercise, and medication, let's talk about that a little bit. I haven't cut out meat completely, although I pretty much am turkey, chicken, and fish, and that's pretty much all I do from that standpoint, just to get adequate protein. But talk a little bit about those 3: diet, medication, and exercise, how they all interact with each other, and your thoughts on that as a reformed triathlete.
So diet and exercise are clearly the most important intervention that we can do. And when you look at population studies and you look at people who have good diet and exercise, they have a 50% decreased risk versus the rest of the population. 50%, that's enormous. You start on a statin, you decrease your risk by about 20 to 30%. Wow. So it's so much more powerful, and it's cheap and it's easy. Well, it's not easy. It's cheap, it's available, anyone can do it. It's not easy though, because it's a daily thing. You have to make that choice over and over again. And you have to try to be consistent about it. You can't just do it one day and not another. But it is important. If I had to say, as far as diet's concerned, I'm changing a little bit the way that I'm trying to approach it, because I know that when I tell people that they should go on a plant-based diet and high fiber diet, they glaze over, right? Or a whole grain diet, they glaze over. So I'm actually changing what I'm doing this year. I'm going to see whether I can be more successful by telling people you need to be on a high fiber diet, high soluble fiber. And the things that give you high fiber are plants, vegetables, whole grains. That's going to do it for you, right? Those are going to be the big 3 that are going to help you. In order to get up to 30 grams of soluble fiber a day, you have to eat a lot of that. And by doing that, you're going to eat less of those other things, because you'll be full. So part of that will be decreasing animal proteins and animal fats, especially animal fats. And then a lot of it should be decreasing processed carbohydrates. So yes, flour, sugar, and those are the big ones. There's also a lot of information coming on about flour and sugar increasing inflammation, and maybe it's the inflammatory piece that becomes important. So a lot to be figured out there. And we can't go into this today because it's such a big topic, is on the microbiome. And it is something that I'm really super interested in, but I don't know whether there's a way of really accessing that information well enough. But there's going to be more stuff coming out. It's all, like I said, a lot more questions are being asked than are being answered yet, but we'll get there.
No, and that makes sense. One of the things, after speaking with you, and then I met with the nutritionist, and one of my sons is very big in fitness, and his wife is a nutritionist and personal trainer, and they were very instrumental in helping me get on a major change from a diet standpoint. And while I didn't cut out meats, I wasn't a big meat eater to begin with, but I would eat fish and chicken and ground turkey, but I added a lot of vegetables, added a lot of fiber. So I eat vegetables 3 times a day. I have egg whites with spinach and scallions every day, and typically lettuce and tomato with lunch and vegetables at night. And that's been a major benefit, just to add the good things, not just get rid of the bad things, the processed carbohydrates and the sugars, but doing a whole grain with oatmeal. And I was trying to figure out how to even spell quinoa when I had my first heart attack. What am I supposed to do with this stuff? And so, but at the end of the day, it's been really instrumental. I mean, losing 35 pounds in 3 months and 4 inches on my waist, it wasn't a goal, but I did. And a lot of that was just changing the diet, but then also the exercise. One of the things you told me, I used to think exercise, that means, all right, get your heart rate up to 155. My max heart rate, according to my age, is 160 beats per minute. But yet you said, no, you don't need to get your heart rate in that really intense high aerobic zone. Talk about that a little bit. Exercise can be walking, right? Just doing a simple, consistent walk.
Yeah, the amount of exercise that you need to do in order to get the most cardiovascular benefit is approximately 150 minutes of walking a week, or 75 minutes or 60 to 75 minutes of jogging or something above that a week. And the hardest thing about exercise is putting your shoes on and getting out and doing it. Anything that you do will benefit you. Doing a lot doesn't necessarily help. It's interesting. We found that patients who do excessive amounts of exercise, more than 5 hours of really, really high aerobic exercise per week, actually have more events than we would predict. Versus people who do just moderate exercise. Not as high as people who don't exercise, but still higher. And that's actually one of my research interests, is trying to figure out in that group why that happens. But all of that being said, just doing something, anything that you like, but doing it and doing it consistently is really, really, really important. And I had one patient who I keep on thinking back on, who had a heart attack in his 40s. He changed his diet and he exercised every other day, moderate levels, and just was really, was consistent at it. And he didn't have his next event until he was 85.
Wow.
And and this was a guy who, when I first met him, I thought, oh man, this is gonna be bad. And he was great. He generally did wonderfully. He didn't eliminate his risk, but it markedly decreased it.
I believe that, and that is encouraging. I love hearing those encouraging stories after I went through my event at 59. And one of the things they had me go through was, and you asked me to go through, was cardiac rehab, where I went 3 days a week to a gym where I was monitored with an EKG. And it was walking, bicycles, some resistance training. And it felt good to know that at the end of that period, I was never really a runner, but I was able to run 1.5 miles just because of going through little by little to make those changes. And for me, with my diabetes being a risk factor, my A1C had been as high as 10.7. It was 9.4 at the time of my heart attack. In 3 months, no additional medication. Everything was still the same, but just by diet, exercise, excuse me, my A1C went down to 5.5. And I look at that and say, nothing to do with meds. Not that meds are bad. My endocrinologist took me off of medication. He said, you're going too low. But it was the diet and the exercise that made that profound impact. Excuse me.
Like I said, it is an incredibly powerful drug, these two things. And maybe we should be looking at them more as a drug. I used to, many years ago, give people, take out the prescription pad and write a prescription for exercise. And I think that it's, and I should probably get back into doing that, but we should think of it that way. And the more people that we do it, I say this very frequently, that I could save the country $100 billion a year in healthcare costs by getting them to stop eating Big Macs and putting on a pair of sneakers.
I believe that. And excuse me, as a quick note, with diet, a lot of times we don't know really what we're eating. I know when my son came up after my second heart attack, he came up to spend some time with me. And he said, what do you have for coffee in the morning? I said, I have some flavored creamer, but it's only a little bit. It's only like 5 grams of carbs. He said, how much do you put in your coffee? I said, I don't know. He said, I want you to pour into an empty mug what you normally use in your coffee. I did that. And he said, now measure it. 1, 2, 3. There were 7 tablespoons in a typical cup of coffee. And I'm like, okay, that's 35 grams of carbohydrates. And I would have 4 cups a day, 2 decaf, 2 regular. And he said, Dad, you're getting your daily dose of carbohydrates just in your cups of coffee before you even eat that Big Mac or that sub. And that was really drastic for me to realize I need to make changes in everything because the little things add up in a massive manner. And that was really eye-opening for me.
Yeah, no, you're absolutely right. 100%. Yeah, it's amazing. Yeah.
No, I was just going to say, we've got some questions coming in. We're going to jump into the other factors we want to talk about, but let's take a look at some of the questions that have come in. One ties to that coronary calcium score. And again, thank you all for asking these questions. When you talk about the coronary calcium score, is that the typical calcium test that comes back in a regular blood test, or is it something different? And you've got access to these, Dr. Nero, by clicking on the questions tab also in your control panel.
There we go. Hold on a second. I'm trying to open up this control panel, but anyway, but I can answer this. This is pretty easy. So, or not easy, but so yeah, the calcium score is actually a CAT scan. You have to do a CAT scan. It's a very quick CAT scan. It takes about 5 minutes to perform, and they'll look at the calcification in the arteries itself. It's a low radiation scan. It's about the equivalent of being on an airplane for about 15 minutes. So it's not a very super high risk for increasing adverse events by doing the scan. And those scans usually cost around $100. So it is worth getting. It's worth, we all have, not we all, but $100 is not going to break anybody's bank to be able to get this information. So I think it's a very reasonable initial study to do. The blood test calcium is not related to this at all, and your serum calcium is not related to your coronary calcium. Supplementation of calcium pills does not affect your coronary calcium. This has to do with a physiologic effect of how the arteries are being healed by something called smooth muscle cells, and I can get into the pathophysiology, but it essentially, as your plaque increases and becomes more or less stable over time, you'll have spicules of calcium that will deposit in them, and we see that from the CAT scan. The CT angiogram, on the other hand, is a little bit more involved. It's again another kind of CAT scan. It's a non-invasive test. They will give you an IV contrast agent to look at the arteries more closely. But the problem for that test is that it's often not covered by insurance, and so it will often cost us approximately $1,200 to $1,500 to perform. Okay. I've had 2 of them done on myself for various reasons, but one was because I was having chest pain while I was training for a triathlon. And I was also lecturing at the time about sudden death in triathlons. I didn't want to be the guy. And it was completely normal. And it was super reassuring to know that my arteries were clean. So that's a helpful thing. And it was, for me, it was worth the money to do that. It would be nice if it was covered more by insurance, but right now we're fighting through that. In Europe, it's a lot less expensive.
Okay. All right, thanks for answering that, or for answering that question. Here's a couple that are coming in regarding drug-coated balloons. The adoption of drug-coated balloons in lieu of drug-coated stents. I read this is being applied in Europe. Do you see this as a treatment option that may be coming to the US? And along those same lines, for the treatment of small vessels, I understand there are now small balloon and micro stenting options versus medical options only. What are your thoughts on those? Thank you for asking those questions.
Those are really cool questions. And the person who asked that question just opened up a big can of worms, so I'm sorry. So the simple answer is drug-coated balloons will be coming to the United States. They do have a role. Their role is extremely, extremely limited. The time when you're going to use drug-coated balloons are 2, when you have something called in-stent restenosis. So you've already had a stent, and then the stent closes back down. When it closes back down, usually it's because of plaque that gets put inside the stent, and so you're going to go in and open that up. But you don't want to put in stent upon stent upon stent, because you can imagine that that tube is getting smaller and smaller and smaller as you put more scaffolding in there. So treatment for in-stent restenosis, that is going to be one of the options. I started using them actually a bunch of years ago while doing some work overseas and working with other labs that had them available. And so I think they're interesting, but there's limited treatments that you're going to give. Maybe for stable disease, you'll also be able to use drug-coated balloons. Unstable disease, if you come in unstable, you're going to want to have a stent, because usually that indicates that the artery itself has ruptured, that there's a flap there, and you want to keep that flat, you want to open it up. And so the scaffolding helps physically keep the artery open and then deliver the drug to the arterial wall. The real question though is, do you need to have any of these things done? And with small vessel disease is not going to kill you. It's the large vessel diseases, the proximal IDs, those things that are going to really cause the problem. It's the heart attack that's going to cause the problem. So small vessel disease is best treated by medical therapy. And I would say that one of the big sea changes that's going to occur in cardiology in the next 5 years is a movement away from going into the cath lab and stenting everybody. We have a couple of trials that showed that stenting, except in very limited situations, stenting doesn't change outcomes. And if it doesn't change outcomes, why would you want to put yourself on a procedure, an invasive procedure that itself can have bad outcomes and side effects to it? And so some people will describe stenting as inducing a new disease state rather than just treating the arterial disease. So the stent doesn't change your risk of having an event because, think about it, the stent's a very small thing and your artery is really long. And so you can have events at any other stage there, and that stent is only helping one little bit of it. The important piece is going to be the medical therapy. And if you have angina, if you have chest pain that is limiting, well, maybe then you stent or maybe you balloon to treat that symptom, but you're not making you live any longer. What makes you live longer is medical therapy with cholesterol lowering, risk factor reduction, especially not smoking, treatment of diabetes now, because in the past, even treatment of diabetes didn't make a lot of difference, but with the new drugs like Ozempic and Mounjaro and Jardiance, these drugs really do improve outcomes. And we can talk about that in a little bit because I know it's a big question.
Yes.
But those are the things that are really going to, and exercise and diet, those things change outcomes. And those things make you live longer. And that's really where we need to be focusing on, not on the stenting. If you're having a heart attack, if you're having an unstable event, stenting is the way to go. I'm not saying you don't do that at all.
Yep.
I'm just saying for stable disease, you want to be very cautious about how you're proceeding instead of inducing a new disease state.
Okay, that makes sense. I want to go answer 2 questions quickly here and then jump back in because we want to talk about stress, some practical steps to restore health, and then the medical anxiety aspect. But a couple of quick questions. First one, I'm going to take a layman's shot at it, if it's okay with you, Dr. Nero, and then I'd like to get your thoughts. It says, if you go back to your 20s and 30s, what would be the 1 or 2 changes you would make in your own life with all the health information, knowledge, and experience that you have now? So from my standpoint, I would have listened to my doctors better, because I felt invincible. I felt, I'm healthy, I've got 9 kids, I live an active life overall, but I've always had a sedentary job, primarily office-based. I would have taken more of the meds. I was stubborn on medication and I wasn't taking it, and allowed years of having high diabetes and high cholesterol. I would have been more active with that. I would have listened to the doctors a little bit better and watched my diet. I've always had a high metabolism, so I could eat anything. I can buy a whole pizza and eat it myself, no issues. And I really didn't gain that much weight. But looking back, I was just destroying myself with doing that. So those are things, and thank you for that question, Nico. I would have absolutely made changes and been a little bit wiser and not thought that I was so wise in my own eyes, and listened to the doctors a little bit better. But Dr. Nero, do you have any thoughts on that question?
I think you answered it. I mean, the only thing I would do differently in my 20s and 30s is maybe I would have married my wife earlier.
That's nice.
Happier and
That's a
healthier.
lot of points on that one.
But yeah, no, that's it, right? Diet and exercise, right? That start there, start early.
Okay.
I do believe that people that have good diets and their kids are around them, that their kids end up having better diets later. So
Yes.
It's not just that you're affecting yourself, it's affecting the other people in your family. So if you can induce change early or be good mentors and role models as far as lifestyle habits, that helps.
Okay, that makes sense. Well, one more question, and we'll come back to the rest of these as we go through. I've got a question here. My cardiac issues run in my family. My granddad had multiple angio and bypass when he was in his late 70s. My mom had 2 angioplasties, 4 stents. Last year, she's 59. I'm 31. When should I start taking the cardiac tests, like an echo? I'm a vegetarian. I eat healthy, don't drink, don't smoke. please share if you have any advice for me. That's a great question. Thank you for asking that.
So it's harder to identify people who are at higher risk at younger ages. And usually I wait to doing any kind of advanced diagnostic testing until they're 40 at least, because you're going to be misled. If you do a coronary calcium score at the age of 30, you won't see any calcium because you won't have had the time to have calcium deposition. If you do have calcium there at 30, it's important because you're clearly at higher risk, but that's a rarity. We might see it in another CAT scan. So there's no testing per se that we would do outside the blood testing. But I do think the blood testing for someone like you, who has this higher family risk and has a clear delineation, you should get your cholesterol test. You should have an LPA test. You may want to get a cholesterol subfractionation. I think those are all important. And then knowing that you're at higher risk should stimulate you to already say, okay, I'm at higher risk. What else can I do with my diet and exercise? And if you can do that and utilize that as a motivation to exercise regularly, et cetera, then you're markedly better off for the future by doing that now.
Okay, makes sense. It makes sense. I'm watching our time. We've got a few different topics we want to get into. I'm watching the time. I want to be cognizant of your time, Dr. Nero, also the audience, since we scheduled this just until 1 o'clock. Let's talk about stress a little bit. Sometimes people say, that job is going to, give you a heart attack, and the whole concept of stress. And you had indicated to me that you weren't so confident that stress had a factor in my case. Talk a little bit about what your perspective is on that.
Yeah, very briefly, it's hard to prove that stress is a risk factor because we all have it. And so when you look at studies that in the United States have looked at it, it really doesn't really fall out. It may be that what's happening with the stress is that we're eating more poorly, we're not exercising as much. Those things end up being the bigger risk factor than the stress itself. But it would be foolish for me to say, oh yeah, stress isn't a problem, because clearly it's a problem, right? I mean, you don't want to do anything. It makes you unhappy. It makes you feel terrible. But so I do think that taking care of stress is important because you're taking care of yourself. And so it's a little bit of a nuanced answer. I realize that because you want to blame something. But I think that maybe doing things that help you with, this is going to sound silly, self-care, right?
Mm-hmm.
It sounds really wishy-washy, but those things like self-care are really important, and that will decrease your stress. Exercise decreases your stress. The benefits of exercise, I don't just think are by making your body work more. It may be due to stress reduction. It may be due to increased breathing and deep breathing. It's why maybe meditation helps. So there's a lot of pieces here that we go together without, I can't say necessarily cause and effect from the thing itself, but I can say that it's clearly associated, and things that reduce stress seem to be associated with better outcomes. So it's not that stress isn't the problem or is the problem, it's all those other things that are around it. I think is the nice way of looking at it.
I think that makes sense. And unfortunately, so many of us deal with stress. I found that just being aware of my breath, of just doing some deep breathing exercises, and even simple things like trying to relax and smile more. There's an ancient proverb, a joyful heart is good medicine, but a broken spirit dries up the bones. And a joyful heart, I've read that even when you smile, that physical process itself releases endorphins. Even if it's a fake smile, it tricks our brain into releasing those happy chemicals. So it's sometimes the simple things really do make a difference in addition to the other things you're talking about.
I'm going to steal that quote and use it. That's a great one.
It's an old proverb actually, but it's true. So the next thing we'll talk about, what about people like myself who've gone through an event? What are some things that people can do, practical steps to expedite the restoration to good health? Exercise, diet, we've already talked about that. What else? And listening to the doctor's orders, which I became better at after my heart attack, what are some practical steps you can think of that can help people along the road to recovery?
That's a really tough question. I mean, I know what I do, but so the first thing is to plan things out. Right. First off, you don't want to get into this situation where you think, okay, it's over, I can't do anything about this. Right. You have to be positive about the fact that the vast majority of people after a heart attack do really well, much better. When we were kids, people died of heart attacks all the
Yeah.
time, right? You went into an ICU, you had a 30-50% chance of dying during that hospitalization, and now it's 1% or less. I mean, it's markedly better. And so we're way beyond where we were in the past. So don't become overwhelmed with it, number one. Number two is you sort of make a plan. Say, okay, I work with my doctors. Obviously, they're going to put me on medications. They're going to put me on a statin. They're going to put me on aspirin. Often they're going to put me on something like clopidogrel or Brilinta or something like that as a secondary thing. We're going to get my blood pressure down. We're going to make sure that my cholesterol are controlled, my diabetes is controlled. And then you're going to take a deep breath and you say, okay, what are my lifestyle things that you're going to change? And we talked about that. But making a plan about how you're going to do it is really key. Sitting down with your spouse, your partner, and saying, okay, what are we going to do today, tomorrow, this week? Let's make a meal plan. What am I going to do for exercise today, tomorrow, this week, next week? If you can do cardiac rehab after a heart attack, clearly there's benefit to cardiac rehab. The benefits seem like they are markedly greater than what you would get just by the numbers of hours that you are there. But the more people do, the better their outcomes are. And it probably is that the more people do and the more consistent they are with cardiac rehab, the better that they do exercise in the future. And that it's not the initial rehab event, but it's the long-term benefit that people get from rehab. Whether it's directed rehab where we tell you what to do and you do it at home, or whether you do it in the office in the hospital. Probably the benefit of rehab, a lot of it is it's giving you the comfort that you can do the exercise without having a problem, and you're not worried about it, and you're doing it, and you're supported through it, and you get all of this positive feedback from the rehab itself. So there's a lot of pieces that come along there.
That makes sense. And you mentioned something there about knowing that people have heart attacks, and yes, the survival rate is much higher than it used to be. When I had my event, it scared me because I'm thinking I correlated heart attack with death, like imminent. And it was really a mess with me here, which is why we have the last topic, and that's the whole concept of medical anxiety. I had both you, my primary care physician, a number of doctors said after an event like this, pretty much everybody will struggle a bit with depression, anxiety. I was in the hospital at one point, and the internal medicine doctor at the hospital looked at my son. He's 21. He was in the room with me, and he said, check your dad's moods because he's going to go through some bouts of depression. And I was shocked to hear him say that. But I found that was unfortunately the case, as you and I have talked about. In fact, I was talking to a client. In fact, he's on the line with us today, and he had an event years ago, and I had to reschedule an event because of something I had happen after the case. Wasn't sure, wanted to go get checked out. And John was very understanding, and he said, look, when I went through this, I had about a year where I felt everything in my chest. Anything that was going on, I felt it. Talk about that. What's your perspective on that? They say it goes away in time, and I'm finding in my case it is going away over time, but it's real, isn't it? What people go through?
Yeah, it's real. It's worrisome. It's concerning, but I do think that it's important not to downplay it at all, because you could also be having a real event, right?
Yeah.
And people do have real events, and you don't want to miss those. So I always tell people, don't worry about calling me. Don't worry about, go to the ER if you need to, and we'll talk about that in just a second. But get it evaluated and make yourself feel comfortable that what's going on with you is normal. But yeah, you will have more symptoms. You're going to be focused in on your chest. It's all right. It's a natural part of that process. 50% of people will have clinical severe depression within a year of having a heart attack or bypass surgery. That's a big number. And I think that when you look at the bell curve of that it's actually very rare for people not to have any effect of that and to say, oh yeah, no, I'm good. I'm good. That would be the rarity. And so you have to accept that. There was a trial where we looked at trying to give people antidepressants after heart attacks and didn't show any benefit. And I don't know exactly why, other than the fact that the medications don't treat everything. And I think that talk therapy is just as good in certain circumstances. And also control, like you've done, where when you take control of your life, you will do better, right? When you make yourself, when you take the responsibility of controlling your medical care, and that's an important one. I do have a podcast somewhere on my list about how to be a better patient, and it goes into all of those little tricks of keeping your own records and making sure you know all the names of your medications and that you have everyone's phone number in your pocket so that you can call your doctors if you need them and all that kind of stuff, because you're taking ownership. And once you do that, you can then get through this a little bit better, just as you have, Jeff. You're doing wonderfully now.
Excellent, thank you. I appreciate that, and I've got a good doctor in you and my primary care. It's funny, Dr. Williams, who you know very well, she had said to me, when you have an event, your brain instinctively will think that anything you're dealing with pertains to that event. In other words, she said, someone who survived cancer, if they have a pain in their pinky, they think they have pinky cancer. There's no such thing, but in your mind, it always goes there. And for me, I have a pain in my chest, my back, my toenails itch. Everything feels like, okay, am I going to have another heart attack? So I think it's normal to feel that. And I agree, talk therapy, whether it's speaking to a counselor, cognitive behavioral therapy, of just self-talk, of just managing the process through that, and having a support system wherever you can, people that will encourage you and motivate you, I think are really important. You said you want to mention something about going to the ER, and then I'm watching the time. We've got about 7 minutes left, and I want to get to some of the questions here. I'm going to drop everybody's hand. If you do have a question, go ahead and raise it. We'll see if we have time to get to some of those. But what were you going to say, Dr. Nero, about emergency rooms?
Yeah, the quick one was the symptoms that you're going to be worried about if you do need to go to the emergency room. Unfortunately, I can't tell you one symptom, but I also often tell people you're going to have a symptom in your chest, whether it's in the front of your chest, top of your stomach, middle of your back, that you have a difficult time identifying. You say, this is just not right. It will often be, although not always, it will often be associated with shortness of breath or nausea or radiating down the arms. It could be either arm. Women have more atypical symptoms than men, but there's no specific symptom that women have that men don't. It's just that they just tend not to be the classic red fox, hey, Elizabeth, I'm coming to join you, honey, heart attack.
Yeah.
It could be a bunch of other things. And when you're having a symptom like this, I say, if it lasts for more than 5 minutes, that should stimulate a phone call to a doctor. If it lasts for more than 10 minutes, you should be going to the emergency room and getting assessed. There'll be times when you'll have that and it won't be anything. And I've had patients who've had classic symptoms of heart attacks, and we've treated them a couple of times. We realized that's not their heart attack symptom. And then you learn biofeedback, and you realize, okay, this isn't as bad or as important. But that's sort of an important sort of thing about when to go to the emergency room and when not to. And I think that's an important one to know.
I think that makes sense. And I've been back several times when there were no issues, but I was feeling something that just felt off, whatever that was. But they would do the blood test for the troponins and everything was fine and it was good to go. But when I first had my heart attack, I had pain in my back. I didn't have the pain in the chest. I didn't have the proverbial elephant sitting on my chest, didn't have shortness of breath. I had sharp pains in my back and a sense of just panic, severe anxiety and it woke me up at 2 in the morning from nowhere, out of a sound sleep. And I said, out of abundance of caution, I'll go get checked out. And that's when I found it. So, and everybody I've spoken to, you included, has said, if you feel something, do something. There's that expression, if you see something, say something. And what I say is, if you feel something, do something. You're better off feeling silly when there's nothing wrong. I'm one of the lucky ones. I feel so fortunate. My best friend said, Jeff, if that was me, I probably would have ignored it and maybe just died. And so it is important. If you see something or feel something, do something and get it checked. So with that, we've got about 5 minutes left in the broadcast here. If we don't have time to answer all of your questions, Dr. Nero, if you have a few minutes, I'll stick around after we close the audio and video portion, if we can answer some of these questions via the chat. But if anybody needs to drop off, we totally understand. I'm cognizant of the timing. There was one question.
By the way, I do have extra time now if you want to continue to go through this, because
okay. So
I think you're going to be publishing this so that people can listen to it afterwards as well.
Yes, this is being recorded, so we'll share it. Absolutely.
Okay, so that way, so we could certainly go on. If people need to drop off, we can always.
Yes, we'll do that. And if those of you need to drop, thank you for joining. But we'll keep going for a little bit longer. And by the way, if you can share any link or information you have on your podcast, you mentioned those a couple of times. And if we can't share it here on the event, I can send a follow-up email to the audience so that they have access to that. There was one question that was asked by email earlier. My wife had a couple of heart attacks 5 years ago, And when she had symptoms, including pressure in the middle of her chest, difficult breathing, she takes a nitro pill and was told 5 minutes later, if it doesn't go away, take another one, another 5 minutes. If it doesn't go away, get in an ambulance, go to the hospital. At what point should we go to the hospital and bypass the nitro if it's more severe than usual? But what are your thoughts on that?
Nitroglycerin doesn't make heart attacks go away. So the nitroglycerin is going to make you feel better, but it's not going to eliminate your heart attack, unfortunately. But the same 5-10 minute rule probably applies, that if you have it for 5 minutes, you should call someone and let them help you decide, because you don't necessarily want to go in every single time. If you're having chronic angina where it's coming back over and over again, that's a slightly different problem than if you're having an acute issue. But if you've already had a heart attack, if you've already had a problem and it's the same symptom and it's severe, go get it checked out.
Yeah.
Like, don't, the fooling around waiting, it doesn't really help you out too much, unfortunately.
Makes sense. Makes sense. We've got a question here from Franklin. I've unmuted, or I'm going to try to unmute your line here if I can. And it doesn't look like I'm able to unmute your line on that, Franklin. I apologize. If you've got a question, if you could type it into the chat or questions area, because it doesn't look like I'm able to open up your line. Here's a excuse me, another question, talking about diet. For vegetarians, would you recommend consuming supplements for calcium, especially those who are lactose intolerant?
No. I'm a fairly famous person as far as saying that supplementation usually doesn't work, and that you're going to get calcium in a lot of other things, including leafy vegetables and other stuff. So even for vegans, unless you're a strict vegan, then there's no supplementation. If you are a strict vegan, maybe vitamin B12 will help. But other than that, I really don't know anything that it clearly benefits. We try to micronutrientize all these things, because essentially the food companies want us to buy their foods and their supplements, and it is a lot more difficult than that. Right? There are thousands of chemicals in a carrot. It's, eating carrots is good, but taking those chemicals one after one, or a different one in different ways, may not do anything, doesn't do anything, has never been proven to do anything. So I don't really say that very much. The calcium supplementation question is quite interesting, because we see people who have low calcium levels. We know that it's associated with bone loss and bone events, but we've never proven that taking calcium supplements actually changes outcomes. And vitamin D, that it doesn't really change outcomes. And we're working on that. I wouldn't say stop those if your physician tells you to take them, but be aware that this is a moving field. It's a moving target.
Okay, Dr. Williams has said the same thing on supplements, and there's another question from someone else along those lines. You mentioned supplements don't work, then do you not need a multivitamin? So do you feel like no?
Yeah, no multivitamin. I very much, save your money, eat vegetables, stop the multis.
It's exactly what Dr. Williams had said. Here's another one on food. What's your take on intermittent fasting? I feel light on my feet when I do the 1 meal a day diet, but some people feel it's unhealthy for your heart. What are your thoughts?
I actually think it is healthy for your heart. But I don't know about every different kind, and there's not a lot of good, you can't do a placebo-controlled study of intermittent fasting. You know whether you're eating or not. And the people who do it tend to be healthier. So there's a little bit of uncertainty. There's a very nice review article in the New England Journal of Medicine, December 26, 2019. And the only reason I know it is right before COVID. But they going over the data that we have on intermittent fasting, and then there was one in the British Medical Journal about 3 months ago, and both of those are available online. Okay. I personally do intermittent fasting about 5 days a week, 4 days a week, where I don't eat. I'll take about a 16-hour break where I eat dinner. I don't eat anything till lunch. I eat a reasonable lunch, and I actually feel pretty good with that. But on the weekends, I sit down with my family, we have breakfast together or whatever. Every time I can have a meal with other people, I try to do that. And so, there's pluses and minuses to everything, but I don't think it's necessarily unhealthy. I don't like the idea of people fasting for multiple days. Okay. That's just me.
And I know for me as a diabetic, when I eat more now, I think, than I did prior to my heart attack, and yet lost weight because I'm eating healthier foods. I'm spreading it out through the day, and I eat an
Mhm.
abundant amount, but again, healthy items. But when I don't eat, if I skip meals, sometimes that can really mess with my sugar levels. So I think some of it depends on if someone has a diabetic
Yeah.
issue as well.
Right, diabetes, you can't do intermittent fasting. You should
Yeah.
not do intermittent fasting.
What are your thoughts? And I'll answer this, my thought first. What are your thoughts on statins? I used to hate them. They provided cramps in my legs. My mom couldn't take them. I said, I'm never going to take statins. And yet, if I had, that possibly could have prevented me from having the heart attack, because statins, like the other medicines you mentioned, Dr. Nero, they can have ancillary benefits that are not necessarily just cholesterol reduction, but they can provide some heart benefits. What are your thoughts on statins?
Oh boy, we could do hours on this one. But I'll answer it in 30 seconds. Statins are good. Statins get a bad rap. I think that for about 5% of people, statins are not a good medication. About 5%.
Okay.
There was a placebo-controlled trial where they looked at side effects from statins, and 20% of people who were taking placebo had side effects, and 20% of people on statins had side effects. There was no difference. So we do believe that there is a nocebo effect from these medications where people are afraid of them and they've gotten sort of a bad rap. I do not think they're perfect. I think that 30 years from now, 40 years from now, we're not going to be taking statins and we're going to move over to better drugs. But we have them right now. And we have about 30 million patient years of clinical data from trials that show the benefit. That's a lot. I don't think
Okay.
there's any class of drug that is as well studied. But it's not for everybody. I'm not going to say it is. And if you can't take them and you need to take them, there are now other therapies, including ezetimibe, a group called PCSK9 inhibitors, inclisiran, Repatha, and Praluent. There's another new medication called bempedoic acid. And then there are other things, icosapent. There's a whole series of things that are coming down the pipe that I think are going to be beneficial for those patients who can't tolerate statins. But you really, it's one of those situations where I really said, people should stop looking at the internet and reading things on blogs, because it can be very, very misleading.
Yeah, I can see that and know that. I see a comment here about your podcast. Can you provide the information? I guess we'll provide that. If not here as a follow-up, we will provide everybody with information on Dr. Nero's podcast. And there's another question regarding medicine. I'm on an anti-inflammatory medicine, 1,000 milligrams a day for joint arthritis. Does that help with cardiac inflammation?
So unfortunately, no. So you're probably taking methotrexate or some variant of that. For rheumatoid arthritis would be the most common. And unfortunately, methotrexate was studied and it did not benefit cardiovascular disease. But this is a really sort of cool, interesting but we have a medication that was tried initially as an anti-inflammatory up the chain of inflammation, something called an IL-6 blocker. The first one showed a decrease in cardiovascular event rates. It was called canakinumab. There was a little bit of increased risk of infection rate, but what happened was there was a decreased risk of 50% of cancers. And so it's being developed as a chemotherapy agent. But it did decrease heart event rates as well. So there's another drug called zilbekimab, which is now being studied out of Harvard. We're involved in 2 of their trials for this. It's another IL-6 blocker, and we're very excited about the possibilities that this is going to improve cardiovascular outcomes. Finally, there is an anti-inflammatory that is available called colchicine. It's an old drug. We use it for gout, but now we have data, fairly strong data, that it decreases cardiac events in patients who've already had coronary artery disease and stenting.
I'm smiling with that because I was just going to mention that some drugs have ancillary benefits. When you put me on colchicine and I started looking up, I said, gout? Why am I taking a medicine for gout? But again, you're saying that they're finding it has other ancillary benefits that can benefit us from a cardiac perspective.
Yeah, the trial was Lodoco and Lodoco 2 were the 2 big ones. There's going to be a few more that are going to be coming out on colchicine. I was one of the more early adopters for that, and there's a lot of people now who are coming up with that. Again, in my podcast, there's a guy named Mike Ricker who we have a nice discussion about inflammation in coronary artery disease and how we're going to be approaching it in the future.
Excellent, excellent. Couple of questions we've got here. One is from a diet standpoint, recommendation in cooking oils, I will say that olive oil always has great, but I use avocado oil a lot because it has a higher smoke point than olive oil. And with that, when I saute vegetables or cook with it, at a certain heat, the olive oil loses all of its benefits, whereas an avocado oil will maintain some of those benefits. That's my layman's answer to that question, Dr. Nero. Any thoughts on that?
Yeah, depends on who you ask. But I think you're right if I was going to guess, but I'm honest when I'm guessing, and I'm guessing. We don't know a lot about, but you're right. Once you heat up cooking oils to very, very high temperatures, they become saturated and they are then more likely to develop pathogenesis. So you need to be cautious about frying anything. But do I cook with olive oil? Yeah, I cook with olive oil, I cook with canola oil, and I cook with avocado oil, depending on what I'm making. I don't try to use a lot of it, but if you talk to Caldwell Esselstyn from the Cleveland Clinic, he was the one that did forks over knives and some other things. He's really adamant, no oils at all. Doesn't like it. Just like they're all bad. Probably it's somewhere in between there. But there's no perfect answer. But if you're going to make a salad dressing, olive oil is usually pretty good.
Yep.
Tastes good.
Yep, I would agree with that. A couple other questions we've got here. One is, what's the benefit, if any, for CoQ10 with statin?
Oh God, I wish I knew the answer to that, because we've never proven it. There were a couple of trials that looked at it and it didn't seem to benefit. So we've never proven it. They make about $1 billion a year selling CoQ10. There's never been a trial that showed that it worked. So I'm intrigued by that. I know what we do know though is that we're not seeing people dying. They're not falling off the face of the earth by taking CoQ10. So my sort of general feeling is, if it works for you, go ahead and take it. I don't start anyone on it, but if they come and they ask me about it, they said they're having some symptoms, they're not sure, they've tried CoQ10, it makes them feel better, I say, okay, that's fine. But I don't initiate it myself, but I also don't stop people from taking it.
Okay. Are you okay for a couple of minutes? I've got two more questions I'd like to ask Dr. Nero. One is, will they use targeted ultrasound to remove plaque in the heart as they are doing for Alzheimer's currently? That's an interesting one.
Yeah, so we are using targeted ultrasound to break down calcifications in coronary arteries in order to be able to deliver stents, but not to actually break down the plaque itself as far as eliminating the underlying or stabilizing the underlying lipid core. That actually can't be fixed with ultrasound. The other issue is that anything that you would be doing with ultrasound in the artery, it involves an invasive procedure and would have the potential side effect or the potential complication rate that would be much higher than anything that we could predict at this point would benefit. So interesting ideas, interesting concepts. We are using them, but in very specific ways and not in the ways that they're thinking about with these other tangled protein plaques like Alzheimer's.
Okay. All right, very good. And then one more question here. I want to hear about SCAD, S-C-A-D. It's uncommon, happens to young women like myself. I was healthy, no meds, and active, but yet had a heart attack. Only to hear there's still research out on it, whereas you can't pinpoint what causes it. I have 2 stents because of this. Is there any way a person can see signs at all or prepare for this? I'm sorry to hear that you went through that, by the way. Thank you for sharing that.
So SCAD is one of the more worrisome and concerning things that, and worrisome from a patient standpoint, that we deal with, because it comes out of the blue in younger people, mostly women, 95% women, and it just happens and you don't know. And then it can come back, but the recurrence rate, although some of them are listed as high as 14%, it's usually down around 4%. And I've actually done work and research in SCAD and been involved with the folks that run the SCAD databases for both the UK and the US. So I understand this, but the problem is we can't pinpoint why it happens. We can't predict who it will happen in. It is not familial. It is not genetic. There's no clear way of treating it other than to support patients through it. Sometimes you do have to stent. We try not to. What's interesting about SCAD is that statins don't work in SCAD because it's not a plaque-based thing. It's just a breakdown of the arterial wall. So it's a completely different entity. It looks exactly like a heart attack. It acts like a heart attack, but it isn't. And then if you look back at that artery after it's healed, You go back in 3 months later, 6 months later, it looks completely normal. It's healed itself. But they can have SCAD in another territory later. Again, very, very rare, but they can have it. The patients who, I'm going to say something that doesn't sound right, who have given me the most problems, but that's not true. The patients who've been the most concerned have been some of my SCAD patients, because it's really difficult for me to reassure them when I don't have the data to say, yes, and this is why, and this is how we're treating it, and you're going to be okay. Other than say, you're going to be okay, but be aware. You're going to be okay, but if you have a symptom, don't blow it off. It's not that you can't ever have another event. It's just it's highly, highly, highly unlikely for you to have another event. But the SCAD research is ongoing. We're really working on it, and there's a bunch of people out there that want to make a difference in SCAD. And I think that there's going to be some cool things coming out about this, but it's going to take years because it's such a relatively rare event.
Okay, interesting on that one. Dr. Nero, we're 13 minutes past the top of the hour. I appreciate you staying on a little bit longer, and to the audience that was able to stay a little bit longer, thank you for that. I hope and trust that the conversation today has been beneficial, that you've been able to find some things that you can tangibly apply in your own life to increase your health and to those around you. Maybe you've been through an event or someone you love has been, that you can support them. Listen to your doctor. There are great doctors like Dr. Nero that are available that have a wealth of knowledge. Don't be the stubborn ones like I was. Listen to your doctors and maintain that path to health. Dr. Nero, any parting thoughts before we conclude the session?
No, it's been really great. This has been fun. Thank you for having me.
It's been my pleasure. Absolutely, my pleasure. Thank you so much, everybody. Thank you for joining. Have a wonderful and a healthy rest of the day and new year. Thank you very much. Bye-bye.